Now we will continue the second part of the lecture, which is about inhalational analgesia. It is a mixture of gas and air. The gas is nitrous oxide and it is called Intonox. It contains equal mixture of nitrous oxide and oxygen. It is used in most labor wards with a quick onset or rapid onset and short duration of effect. It started rapidly. Once the woman taking inhalational few breaths, she will have good analgesic effect and it disappears rapidly from the body. It has side effects, for example, nausea, lightheadedness, and it is of no use for early labor, as if the woman experiences hyperventilation, she can experience hypocapnia, dizziness, tetany, and fetal hypoxia. So it's preferred to be used once you expect labor will complete within minutes. It is of benefit for late labor, for example, in the second stage or while waiting for epidural analgesia. And this is the containers for nitrous oxide, and this mask is put on the female face to take breaths. Epidural analgesia, it is the most reliable method of effective analgesia, and the decision is combined one between the woman. You should explain for her everything about this method of analgesia because it is interventional, and between a special midwife and obstetrician and the anesthetist with good experience in such method of intervention. Usually the woman is the important part and she should have no contraindication for this method, which is coagulation disorders. For example, she had some bleeding disorder or she is on antithrombolytic medications. Local or systemic sepsis, because it will be the source for meningitis or encephalitis. If she had hypovolemia, for example, she presents with severe bleeding or abruptio placentae, or she is in shock, so it is not a useful method for or good choice for analgesia. If you have no trained staff for such intervention, the main indications are prolonged labor, maternal hypertensive disorders, because one of its side effects is hypotension, so it is of benefit for these cases. If you have multiple gestation, if there is maternal diseases, special medical disease, that we should not let the woman enter into severe pain because pain may exacerbate her medical condition. If there is high risk for operative intervention, so I will provide epidural analgesia, which in turn can be changed to anesthesia. Advanced cervical dilatation on its own is not contraindication, but the progress of labor and the time length for it and the type of labor is important. That's to say, if she presents, for example, with 8 centimeter cervical dilatation or in second stage, I will not choose this method because it is chosen for providing analgesia for longer period of time. Counseling with the mother about the epidural analgesia and its complication is a mandatory step, as we mentioned. The techniques include intravenous crystalloid supplements prior to initiation of analgesia with 500 to 1000 ml of ringer or normal saline, because the side effect, as we mentioned, is hypertension, so it's preferred to give this pre-medication. Also, you provide an IV access in cases of any emergency happens. The epidural catheter is placed in the epidural space, usually at level L4-5, but sometimes L3-4 or L2-3 interspace. This space contains blood vessels and nerves and fat, so it's better to start with testing dose. And this picture shows to you the place of the catheter outside the dura, so it will not enter into the subarachenoid space, and the needle is put there, the catheter passes through it and fix it in that area to give supplements analgesia. The mother should not lie supine to avoid aortocaval compression, and so hypotension can be exacerbated from the medication and from the position of the mother. Opioid analgesia can be used to decrease the dose of local anesthesia. Regional analgesia is maintained by intermittent dosing or continuous infusion or both of them. Regarding spinal analgesia or anesthesia, this needle of a small gauge can be entered into the dura, into the subarachenoid space. A small dose, smaller than that one used for the epidural analgesia, is put, and usually it is of bupivacaine or xylocaine, and it is used in anesthesia for cesarean section or for removal of retained placenta in cases of instrumental delivery trial in theater or for repairing difficult perineal or vaginal tear. Sometimes we used combined spinal epidural analgesia, and this is of advantage in getting rapid onset of pain relief with the spinal one and then prolonged analgesia provided with the epidural catheter. Complications of epidural and spinal anesthesia, the main complication is hypotension, and that's why we should provide with pre-medication of IV fluid. Headache, if accidentally dural puncture during the epidural analgesia, it results with spinal headache. As the epidural needle is wider bone, so leakage of CSF fluid will happen more. You should advise your patient not to lie flat, without using any pillow, and to avoid sitting upright position. Sometimes if it is severe, you can inject blood, maternal blood of the same woman in that side to close this puncture or provide systemic or oral analgesia. Accidental total spinal anesthesia, if the injection of epidural doses into the subarachnoid, as we mentioned, the epidural doses is larger than that one used for spinal anesthesia. This will cause severe hypotension, respiratory failure, unconsciousness, and sometimes death. The mother required intensive care unit with intubation, ventilation, respiratory support. Urgent delivery may be required to decrease the aortocaval compression and permit resuscitation. Neurological complications, which are very rare and sometimes due to other factors coincidentally. Drug toxicity, if we wrongly inject the anesthetic material into blood vessels, so it will cause systematic toxicity from this medication. Bladder dysfunction, as the woman is unaware if the bladder is full, so it's better to put a catheter and remove it once disappearance of the effect of this analgesia. Backache plus minus, sometimes it is not documented that backache is due to this type of anesthesia or analgesia. There is increased incidence of instrumental delivery but not the cesarean section. Now we will talk about the pudendal block. Transvaginal route or transperineal needle passes medial and inferior to the sacrospinous ligament and the ischial spine. You should aspirate first to be sure that it is not the vein or the artery that is injected. 7 to 10 cc of each side with xylocaine 1%, and it is used for pelvic outlet manipulation in second stage of labor. The complication could be systemic toxicity if you IV injected this medication, vaginal laceration, vaginal or ischiorectal hematoma, and retrosavus or subgluteal abscess. Perineal infiltration, it is method used for episiotomy. You inject locally xylocaine at that area. And thank you.